All right, guys, the shout out for this week is our listener from India, specifically the region of Tamil Nadu. Thank you for listening. We appreciate you. Thanks for tuning in.
Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question you don't know the answer to, you'll be able to fall back on these principles to formulate a decent answer and reason your way out of trouble.
Okay, shock. So to understand shock, we're going to go through some of the first principles
Lovely.
of shock.
Shocking.
Yeah, it's a shocking truth. Okay. So I just want to run through some very basic concepts, real basic. Can anyone tell me what the purpose of systemic circulation is?
To live.
You're right in a way.
To
but I
perfuse
wouldn't-
your organs and tissues to live.
Yeah, so perfuse, deliver oxygen. Anything else?
Get rid of waste.
Yeah.
Get rid of waste. Yeah, perfect. So the purpose of systemic circulation is to deliver oxygen to tissues and pick up waste products like carbon dioxide. And what is the role of oxygen? What's the purpose of delivering oxygen to tissues?
Metabolism.
Yeah. Because tissues use oxygen to produce energy. And how do we measure systemic circulation?
Blood pressure, heart rate.
Yeah, blood pressure, right? Blood pressure, you think about it, is
Okay,
like
yeah.
the main measure of systemic circulation. And what is that controlled by? It's an equation.
Cardiac output and
Yes.
systemic vascular resistance.
Yeah.
Give you map.
Yep. So blood pressure is equal to cardiac output times systemic vascular resistance. Okay. And what is cardiac output determined by?
The equation for cardiac output.
Yes. What is the equation?
Heart rate times stroke volume.
Yeah. Heart rate times stroke volume. And a key factor which plays a role in determining stroke volume is preload. Okay. And what are some factors we know that affect preload?
Vascular, like volume.
So simply how much fluid you have in your blood vessels. That's a simple way of thinking about it. Okay. Intravascular volume plays a key role in determining preload, therefore stroke volume and cardiac output.
Yep.
Okay. Does that all make sense?
Yep.
The next key concept is hypoxia. Can anyone give me a quick definition of what that is?
Lack of oxygen in tissues.
Yes.
What is it in blood?
Hypoxemia.
Nice.
Yeah,
Because
okay.
anemia is blood. Yeah.
Great.
Like anemia. Upcoming episode.
Another key concept is lactate. Can anyone give me a rundown what lactate is?
It's a byproduct of anaerobic metabolism.
Yes. So it makes sense that there is a raised serum lactate when there is tissue hypoxia because the tissues can't use aerobic metabolism and therefore have to switch to anaerobic metabolism, resulting in the production of lactate.
Yep.
I'm pretty sure the lactate that you measure is the conjugate base of lactic acid. So when you measure the lactate in someone with tissues, it's just a correlation. So you're not measuring the lactic acid. It's just like lactate's the conjugate base of the lactic acid. So if lactate's up, that means the lactic acid's up. So I'm pretty sure that's why you measure lactate.
If lactic acid up, that's causing the lactate to go up.
Yes.
Is that
Yeah.
right? Yeah.
Is
So
that
that-
like equilibrium sort of
Yeah,
shifts to the right? sort of-
Yeah.
That's great. Yeah, I didn't realize that. And last key concept I wanted to go through was acidosis. Basically, acidosis a lot of the time is a byproduct of tissue hypoxia
Mhm.
because your cells just can't regulate themselves properly. Okay. So those are the real basics. Were they basic? As you would
Very.
say? Very.
Basic.
Okay.
Uh-huh.
Okay. Next thing I wanted to go through was the definition of shock. Okay. And this is all about oxygen. Can anyone give me a definition of shock?
I know there's the word systemic in there somewhere.
Probably reduced systemic perfusion to meet metabolic demands.
Brilliant, man.
Something on the lines of that.
Yeah, Nick, mate, you're on fire today, man. So the definition of shock I got was that shock is a life-threatening state of cellular and tissue hypoxia due to either and or a combination of reduced oxygen delivery or increased oxygen consumption or inadequate oxygen utilization. Okay. So it could be either of those or all three combined. Does that make sense to you guys?
Yeah.
Okay. Shock most commonly occurs when there is systemic circulation failure, and that's usually manifested as
Heart failure.
blood pressure
decrease. And
What's the blood pressure decrease called?
Hypertension.
Hypotension. Yeah. So what I was trying to say was that shock, it's usually hypotension, but sometimes can be hypertensive or normotensive. The next thing I wanted to go through was trying to understand what shock really is. So it's important to realize that shock is a physiological continuum, okay? And it begins with an inciting event that progresses through 3 stages. So the first stage is pre-shock. Can anyone describe what pre-shock would be?
It's like compensated shock.
Mate, that's the exact word I wanted.
Okay.
Compensated shock, okay? So essentially you have adequate compensatory responses to diminished tissue perfusion, okay? You may get some mild tachycardia or mild changes in blood pressure or even like a mildly raised serum lactate as a result. But your compensatory responses are working, right?
if it's compensating, why is there tachycardia? Or it's just mild tachycardia?
It's just a mild tachycardia. So it's handling it at the moment, but then it can also progress to the next stage, which is,
decompensated.
or just shock.
Yeah.
So this is what happens when those mechanisms we talked about are overwhelmed, okay? And you start to get signs and symptoms of organ dysfunction. So you may get severe tachycardia or severe hypotension. You start getting shortness of breath, acidosis, cool, clammy skin and peripheries, okay? So those are kind of signs that your body's not really handling this stuff well. It's losing a bit of control.
This is where you get the clinical features more so than the decompensated.
Or you get more severe clinical features, I would say, compared to pre-shock. And the last stage, can anyone guess what that would be?
Death.
Death? Close?
Yes.
Life.
What's right
Post-shock.
before death?
Organ failure.
Yes, organ failure. Okay. So end organ dysfunction or organ failure, right? So basically what happens if you leave shock untreated, it leads to irreversible organ damage, which then leads to your favorite complication,
Death.
death. Okay. The whole talking about the 3 stages of pre-shock, shock, and end organ dysfunction was that it's important that you recognize shock early and treat shock early to prevent progression to irreversible organ dysfunction or organ failure. Okay. So you got to recognize it early and treat early.
So is stage 1 and 2 still reversible?
Yes, essentially. Yeah. So pre-shock and shock is when you want to be ideally treating shock, but it just depends when you catch it, right?
I mean, I've seen people treated in stage 3 as well, and they survive.
Yeah, you still get treated at all stages, right? But ideally,
Is it
you wanna-
reversible in stage 3?
Yeah. If it depends on time again, if it's like
Oh,
longer
yeah.
you leave it.
there's no like clear cutoff. It's more like thinking about like theoretically about the different
Which stage
stages,
they're at,
right?
yeah.
Yeah.
You're not going to be like, oh, this patient's in pre-shock. Like, you're going to be like, oh, they could be going into shock here. Like, just a way of thinking about it. So those are the first principles of shock. Okay. Can any of you give me a basic summary of that? What I've gone through? Go on, Nick.
So shock is where we have a lack of oxygen and perfusion to tissues, either a result of increased demand, inadequate perfusion, and increased utilization.
Unable to utilize that
Oh,
oxygen
right.
or whatever.
Okay.
right?
Or
Yeah,
essentially
yeah.
metabolic
Yeah.
demands.
Shock can be classified into stages, a spectrum. So we've got pre-shock, where it's mainly compensated. So they might just have a mild tachycardia. And then you've got shock itself, where they teeter into decompensated. And then you've got sort of aftershock.
God damn, that's good. That sounds
Post-shock.
so much cooler, man. My patient just went to aftershock. Man.
And organ damage.
Yeah, organ damage, right? Okay, great. So shock, as Nick summarized fairly well there, can actually be broken down into 5 main
I
types.
know
Okay.
this.
By understanding these 5 types, I think it helps you understand the management of the different types of shock. Okay. So Jay, man, you're MD3. You should know this shit. This is MD4 stuff here. Do you want to give us one type of
I can
shock?
give you all 5 of them if you want.
No, sharing is caring, man.
Let's
give one.
go with cardiogenic shock.
Cardiogenic, of course, Mr. Cardiology here. Okay, cardiogenic. Yeah, what's your understanding of that?
Basically, when the heart fails to pump, fails to maintain the blood pressure, and the fast cardiac output, all that falls, getting end organ perfusion.
Yep. So the key things, cardiac output you mentioned, and it's a cardiac cause of pump failure. Okay. So cardiogenic shock is due to an intracardiac cause of pump failure, that results in reduced cardiac output. Just the heart, okay? Not the pericardium. Talking about the
What
the
about
thick,
like a
juicy boy heart, okay? Nothing more, nothing less, okay?
yeah.
Just that heart, okay? Okay. Intracardiac cause. Remember that, okay? And cardiogenic shock can be broken down into 3 various subtypes. And can anyone think about that? Okay, give me 3 categories. Just think of various functions of the heart or things which can go wrong with the heart. I'll give you one to get you started on. Okay, cardiomyopathy. So that would include things like a myocardial infarction
Mm-hmm.
or when you've got an exacerbation of heart failure. Can anyone give me another type?
Valvulopathy?
Valvulopathy, yeah. That's part of the mechanical subcategory, which refers to like a valve rupture or when you have a ventricular wall rupture. And the last category,
Conduction.
conduction. Yes.
So like branch block.
So you can get bradyarrhythmias like complete heart block, or you can get high heart rate conduction problems like VF, VT, atrial flutter, atrial fibrillation. Okay. So, Mr. Cardiology, can you break down cardiogenic shock for me now?
So you have cardiomyopathies, you have mechanical defects, then you have your conduction defects.
Okay. And give me a nice definition of cardiogenic shock now.
It's an intracardiac cause of shock
Yes.
with a failure of the pump.
That results in what?
Reduced cardiac output.
Yes.
Use those
my
keywords. This
man.
guy just
Okay.
wants to hear those
Keywords.
Cardiac
keywords.
Yeah.
output, intracardiac and cardiac output. Okay. So let's go through another one now. JT, can you give me a type of shock?
Hypovolemic shock.
Hypovolemic shock. So do you want to give a definition of that?
When there's reduced fluid intravascular volume in the body, resulting in decreased systemic perfusion.
I mean, I take that.
So there's a reduced intravascular volume, which
Mhm.
results in reduced cardiac output. So how would you categorize various types of hypovolemic shock? I'll give you a hint. It can be broken down to like this type and this type. Think about the blood.
Hemorrhagic and non-hemorrhagic.
Yeah. Okay.
Oh, I said blood. I think you said blood.
Think about
I'm
the
like,
blood. Okay. So hemorrhagic, right? You could have just anything which causes you to bleed, right? Trauma, GI bleed, post-op, ruptured ectopic pregnancy, okay? Non-hemorrhagic, can anyone think of stuff? What causes you to lose intravascular volume?
Too much diuretics.
Diuretics.
Nausea, vomiting,
Yeah, anesthetics,
and
man.
diarrhea.
Great.
Skin.
Oh, like
burns,
burns.
like burns and stuff.
Yep.
right?
Yeah.
You even get, renal
Bowel obstructions and
losses,
stuff
GI.
like
Kidney issues.
Man, there's a ton of causes. But yeah, can be broken down to hemorrhagic and non-hemorrhagic types of shock. Okay?
Damn, so many
Or
categories.
bled, like Jason said.
But you got to think biologically, man. Okay, next one, Nick.
Distributive.
Distributive. Okay.
So
3
Give me-
categories. Or
This
is
Give me
it?
is,
that
uh,
definition.
my definition is increased vascular permeability, leading to extravasation of fluid, but maintenance of
God
total
damn.
blood volume.
Yeah. I just said due to severe peripheral vasodilation, resulting in reduced systemic vascular resistance.
Maybe you
Yep,
should change your
sure.
definition, dude.
Okay.
Anyway,
And like all the other types of shock, it can be
there's
broken
classification.
down.
You're joking.
So it's very similar to the hypovolemic one. Okay.
I can only think of like the different subtypes. Like you've got like sepsis and anaphylaxis
Well, okay. So sepsis is just one big category.
Yeah,
This
yeah.
is one of the most.
and non-septic.
And non-septic. Mate, you're right. I'm
Is
not
it actually?
Yeah, yeah.
Are you joking?
I'm not even joking. It's septic and non-septic.
Oh,
okay?
let's go.
So septic, as we've gone through in previous episodes, is due to a dysregulated host response to infection,
Mm-hmm.
resulting in life-threatening organ dysfunction. And it's actually the most common cause of distributive shock. So then
Right.
non-septic, they have a few different categories. You mentioned one.
Yeah, then you've got like neurogenic.
Neurogenic, yes. So that's the interruption of the autonomic pathways
yep.
when a patient has a traumatic brain injury or
Mhm,
spinal cord
mhm.
injury, and that leads to reduction in the vascular resistance. Next one, neurogenic, we've gone through one.
Anaphylactic.
Anaphylactic, right? So that's an IgE mediated allergic response to allergens like peanuts, for example. Anything else? JT, you know what? This is related to your fucking thyroid episode. You better get this right.
Myxedema coma.
Myxedema code. So that's an endocrine type of shock, right? And what's another thing you have to check? Think about thyroid emergencies. What else do you have to rule out?
Adrenal insufficiency.
Yes, Addisonian crisis. Fuck.
Is that just because of the drop in blood pressure and loss of
Yeah,
tone
you
and
don't
stuff.
have steroids
Right.
which are involved in maintaining blood pressure. So Addisonian crisis and the myxedema from thyrotoxicosis is a type of endocrine shock. And the last one we have is inflammatory shock. Okay. So that's the systemic inflammatory response syndrome, or SIRS, which is
Oh, yeah.
caused by things like burns,
Oh.
pancreatitis.
Is that under
Distributive.
distributive shock?
Yes. This is under the non-septic branch of distributive shock.
Yep.
Okay.
Jeez.
So we've gone through distributive, cardiogenic, and hypervolemic. There's two more.
Obstructive,
Obstructive. Okay. So give me a definition. Extracardiac.
extracardiac cause that reduces cardiac output.
The definition I got was that it's an extracardiac cause of pump failure that's often associated with reduced right ventricle output. And this will help you understand the various subtypes. Okay. So one of the subtypes is pulmonary vascular.
Okay.
Can anyone think about what would be the causes of a pulmonary vascular kind of obstructive shock?
PE. Yeah.
PE, baby, PE.
Yep.
Okay. Another cause could be a severe pulmonary hypertension. Okay. But PE is one of the classic causes of obstructive shock. And the other subtype is mechanical. So can you think of anything which can cause your heart to fail because a lot of pressure? Think about
Cardiac
pressure around the
tamponade.
heart. Cardiac tamponade. Anything else? Think about stuff around the heart which can put pressure on the heart. And,
Obesity.
well, unless they've gained like 20 kilograms of weight, maybe from like fluid overload, I don't think that is a acute cause of shock, man. So you said tamponade, okay? Tamponade causes increased pressure in the heart. Right? What are some other things which increase pressure in the thorax, okay? What can increase
Like
pressure?
a tension pneumothorax?
Yes, tension
Yeah.
pneumothorax, right?
Those things.
Or a hemothorax, okay? So those are the classic causes of an obstructive shock. And the last one, okay? This is my favorite one because it's the easiest one to remember. Can anyone guess what that would be?
Mixed
Yes,
shock?
mixed or combined shock.
Oh.
Easy, right?
So there really is
So-
only
Bit of everything.
four.
There's really only four.
Yeah.
Hey,
Yeah.
you want to sound smart? You say the fifth one. You don't start with the fifth one, but you say the fifth one, okay? So what would be the definition of combined shock?
Just features of everything.
Yeah.
Just a bit of
And
Tension pneumothorax, a little bit of sepsis on the side.
but really, that's the reality, right? So a classic example is that, let's say you have a patient with acute exacerbation of heart failure, right? They may be in hypovolemic shock because you've over-diuresed them. And they could be in cardiogenic shock because they've got inadequate cardiac response. So they can't raise their stroke volume or their cardiac output enough to meet demands. Okay. So does anyone want to go through all the 5 types of shock and give me a quick
JT looks
summary
up for it.
definition for each one?
All right. So I'll start off with the heart because it's all those intracardiac causes. And then I'll go outside of the heart. So the extracardiac would be the obstructive causes of shock. And then I'm thinking about the things before the heart. So pre-heart, I'm going to classify as hypovolemic shock. And then the last one is sepsis, inflammation, distributive shock. Because it's after the heart, right?
I haven't thought about it
Whatever.
that way,
Yeah.
but you know what?
Yeah,
It's
it's
not
a
a bad
good way to
way.
think about it. Like
And you forgot the most important one, bro.
Come on, man.
Combined shock, hey?
Cop out
Combined
answer.
shock. It's like when they say, oh, what's a risk factor for this condition? Age. Yeah. Okay, now that we've gone through all the types of shock, we're just going to go through an OSCE kind of style case example, okay? Because remember, shock is a life-threatening condition. It's very high yield. Okay, so imagine you are all interns at a tertiary hospital working a night shift, guys. You've been called to see a patient on the wards who has become unwell and has a blood pressure of 75/40. Please examine the patient using an A to E approach. Can
First thing
anyone
I'd say-
start? Start with the A.
I would call for help.
Oh, yes. So call for help first. Now let's go through A.
Check the airway, any obstructions, patency. If they have any fluid inside the oral cavity, try to suck it out.
If they've got like noisy breathing, or do they have this angioedema or any obvious like urticaria that may suggest like anaphylaxis.
So airway done. Now go into B for breathing. What would we go
Check
through?
for the symmetrical expansion of the chest. If it's not, it could be like a tension pneumothorax or something.
You probably haven't covered this yet, but there's a mnemonic rates that you should go through. Try to guess it, Jay.
For respiratory rate.
Yeah, that's for us. Yeah, good.
Stethy steth.
Okay, I'll school
Yes.
T.
Yeah,
T is Trivial deviation.
Yeah, good, nice. And then you kind of said it just now, but respiratory effort is
Right,
E.
effort, right?
And then last one, you also just,
Saturation.
yeah, that's right. Yeah.
So rates, as JT said. And a few other things you want to include is seeing if the patient requires oxygen therapy, usually via like a non-rebreather. So you
Mhm.
want to determine that. And you may want to request like a chest x-ray or a fast scan. So fast scan is just an ultrasound they do at the bedside to
Yeah.
determine like any major bleeds.
Yeah.
Okay, so for breathing, we go through rates, oxygen therapy,
Mhm.
and requesting chest x-ray or fast scan.
Yep.
Okay. And now for C.
Circulation. So this is where you'd want to gain IV access.
Yep.
So get 2 wide bore cannula, and then you'd want to start them on perhaps a fluid bolus, or I guess depending on what you're thinking, you might want to start fluid bolus in one arm, antibiotics in the other.
Mm.
If they're hemorrhaging, blood products. Yeah. So you want to look at their heart rate as well, but I'm assuming
Dude,
You've looked
no,
at that.
for someone who hasn't gone through ALS, not a bad idea. But
Anything else you want to add, Jay?
Check his vitals
Yep.
and then
Yeah.
take some bloods if we can as well.
yeah.
Good.
So-
Very good.
one thing with circulation is that there are a lot of steps, right? And
Mhm.
it's easy to forget steps if you don't have a systematic approach. So one of the tutors for the ALS, they taught me a good way of remembering all the different steps as part of circulation. So imagine a circle, okay, which starts from your fingertips, goes up towards your hands, arms, and then neck, chest, and then suprapubic region, okay? So for circulation, so starting off with your fingertips, what do you want to feel for?
Cap refill.
Before cap refill?
Look.
look at their skin. Is it mottled and
Yep. So you want to feel the
Clammy.
fingertips and see whether they're warm or cool. Okay.
Mhm.
That's an important sign to look for. And then moving slightly up, you want the peripheral capillary refill time,
Yep.
as I think Jay mentioned. And then imagine you going up towards the wrist,
pulse?
pulse. Yep. And then you're hitting those beautiful, juicy veins in the ACF. What do you want to do then?
Get your IV access.
IV access. Okay. Run some blood tests. And do you want to go through the blood tests we usually go through?
VBG, FBC, UEC, LFT, CRP maybe, coags maybe.
Yes.
BCs.
Blood cultures.
Maybe.
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 And a group and hold, right?
Yes,
Oh,
yes.
yeah.
And in particular, the VBG is often used in the acute setting. Can anyone tell me why?
You can get a lot of information from it. Like
What specific
like
information?
a glucose, the acidosis and stuff.
Yes, so acidosis. What other marker, which we discussed at the start?
Oxygen. You can get a PO2 lactate as well.
Yeah, so pH, lactate. That's how you get a serum lactate through VBG. Okay. So you had the ACF, you've done those blood tests. And then, as Nick said, yeah, you consider IV hydration or blood
Right.
transfusion.
So I got a bit too keen there.
Yeah, you
Take some bloods first.
I like the enthusiasm, man. But
Yeah,
I'm just
yeah.
saying that when we have our OSCEs and you're doing the simulation, right, it's
Mm.
very easy to forget one of these steps.
Yeah.
You know, if
Mm.
you go straight to the ACF, you'll forget to touch their peripheries and
Mm.
see where they're warm or cold or get their radial pulse. Okay.
Okay.
So imagine you got IV access done. Okay. What do you do right above the
Flex their
You do
bicep.
blood pressure.
blood
Flex
pressure? Yeah, bicep for blood pressure. Okay. And then imagine now you're going to the neck.
Elusive JVP.
Yeah, every physician's favorite sign, especially cardiologists, man. Fuck, cannon waves. I don't know.
Cannon
No one
waves.
can read that shit. Okay. JVP. Okay. And now imagine you're going down from the neck. What do you do?
Central refill time.
Yep. Central cap refill time.
I was going to say auscultate.
Yes.
perhaps.
Auscultate for
rest
heart
sounds.
sounds
3-lead ECG.
and ECG. And now finishing right at the end near the suprapubic region. What are you checking for?
Renal arteries.
Not renal arteries, but you want to look at their urine output, right?
Yep.
Because that's a function of cardiac output. So that's a nice systematic way of remembering the circulation step of
Yep.
the A to E approach. Okay.
Good.
Now for D, the disability. So can anyone think of stuff you want to look for?
GCS.
GCS or even AVPU? That's
Mhm.
good.
Glucose.
Glucose, so blood sugar level, right?
Pearls.
Pearls.
What
so,
is pearls? That the eye thing? We put
Yes.
the,
Yeah.
Yep. So you want to look at pupil size and reaction to light, right? So GCS, pupils, and BSL. Those are the classic things you got to say you're looking for when you're checking D. Now for E, the environment.
you exposed. Not the secondary, isn't it?
Yeah, you want to expose. Yep, no, that's
With
right.
dignity.
With dignity. What are some things you want to look for when you're exposing the patient?
Like bruising,
Bruising.
injuries.
Bruising, a rash is also really important to
A
look
good
for.
one I got told is look for a med bracelet for an
Yeah.
anaphylaxis reaction.
It's like your answer's right there, man. Like,
I mean, you should probably look for that at the start.
So expose the patient, and the last part of environment is temperature. I didn't want to confuse you, but this guy even said that during the circulation step, you can remember to put a temperature probe in their armpit as part of that circle
I
of
thought I was going another way.
part of that circle of circulation. So now we've done the A2E assessment nice and systematically. You're trending pretty well on that OSCE, okay? Getting those 6 out of 6s, okay? So you've given some IV fluids and their blood pressure is stabilized, but you are still unsure as to what has caused his shock. You find out that the patient is John Smith, a 62-year-old man who is day 5 post a total hip replacement and is febrile. Just say you've stabilized them, you've gone a bit better, right? So what is your next approach?
Now you want to investigate the cause, yeah?
Yes.
Yeah.
So you want to figure out the cause of their shock.
Yeah.
Okay?
Sure.
That's right. So you want to take a history, and the history can probably point out to what the cause is. Okay? So yeah, we don't need to go through a history because there's a lot of things you can ask about. You can go through any pain or past medical history, medications, blah, 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 blah. Okay? So now you think it could be an obstructive shock from a pulmonary embolism or a distributive shock from sepsis. How would you tell the difference on examination? Hint, hint, there are some important signs to differentiate different types of shock.
JVP.
JVP, yes, that's one of them.
Would there be any signs for a PE? I don't think there would be many clinical signs.
Calf tendons.
Unless, they've got like some calf tenderness.
Yeah.
Yeah.
That's not bad.
For sepsis, I think, again, like I said, look at like sources. So
I'll give you a hint. I'm not discounting all the other ones. Like calf tenderness, of course, very important and will definitely point you towards PE or something like that. But these are 3 generic things in the AT assessment which help you determine what the type of shock is.
all 4 shocks you can just tell from these 3.
Kind of.
Okay.
Kind
all
of.
right.
Heart sounds?
like blood pressure or heart rate.
Muffled or something.
Yeah,
you know?
well, they're already in shock, right? All these can
Yeah.
kind of cause that type. Help you out. So JVP, peripheries, and
Clinical
lung
hydration.
Sounds.
Oh.
Lung sounds.
Lung
okay?
sounds.
Or
Oh
breath
yeah, they
sounds.
could be in like pulmonary
Okay.
edema.
So there's this cool way of thinking about it, right? So the University of Calgary, the Black Book, does a really cool approach, okay? So this flowchart is on the Notion document if you want to have a look. But basically, it's a flowchart. So you suspect a patient's in shock. So this is just only for examination findings, right? And then you want to feel for their peripheries. Warm extremities point you to one type of shock in particular,
Distributive shock.
distributive shock, right? And what type of JVP would they have in a distributive type shock? Think about where the fluid's going.
Be decreased. Wouldn't
Yeah, a low JVP, right?
Mhm.
Okay, so now think about the cold extremities branch, right?
Yep.
That can be broken down into high JVP and low JVP causes, okay? So if you've got cold extremities and low JVP, that's typically one type of shock. Can anyone guess what that would be?
Hypovolemic.
Hypovolemic, yes, that's
So your
correct.
hydration status is low and you're not getting enough volume or blood into your peripheries.
That makes sense.
Mhm.
Now for cold extremities with high JVP, you may get two types of shock,
obstructive.
okay? Obstructive is one.
Cardiogenic.
Cardiogenic, right? And how would you tell the difference between cardiogenic and obstructive shock? It's based on one of those examination steps we were talking about.
Lung
Listen-
sounds.
lungs.
Lung
Yeah.
sounds, right? Okay. So what would cardiogenic shock have on respiratory auscultation?
Coarse crepitations.
So lung
APO.
crackles, right? Whereas obstructive shock, what could that possibly have?
Lung sounds.
So normal
Clear
or
lung
even
sounds.
decreased breath
Yeah.
sounds, right? So does that make sense to
Why
you guys?
decreased?
Yeah.
Because it depends on what the exact cause
But
is.
there's like
right?
a tension pneumothorax.
Yeah.
Yeah.
Or even cardiac tamponade can reduce your breath sounds, pretty sure. So Nick, can you give me a little summary of that, of those examination
Yeah, sure.
signs?
So the examination signs, there are 3 key examination signs to help you distinguish between the 5 types of shock. And these include peripheries, so feeling whether they're warm or cool, JVP, and lung sounds. Now, if the peripheries are warm, you can be quite confident that it's a distributed type of shock. And with cold peripheries, you can take further steps with looking at their JVP. And if the JVP is low with cool peripheries, it's going to be hypovolemic. And if you have raised JVP and cool peripheries, it can either be obstructive or cardiogenic, and that's where you listen to the lungs. So if you listen to the lungs and you hear crackles and you think this may be APO, you're going to lean towards cardiogenic. And if they're normal or reduced, you can probably lean towards obstructive.
Thank God I got you to do that over JP, man. Fuck. That was beautiful, mate. That was one of the best summaries.
Thank you.
Okay?
Thanks.
Anyway, now let's get back to the case, right? The patient's peripheries are warm to touch with a low JVP, and you notice their IV cannula side is red and looking infected. You are now confident that the patient is suffering from a distributive shock caused by sepsis. How would you manage this?
I'd call for help.
Yeah. But we want to treat the underlying cause of the shock. And as you all know, and as avid listeners of the show, we have gone through sepsis, right? We have gone through the sepsis 6, okay? Nick,
Yeah.
have you fucking listened to our show, man? This is the case.
I have, man.
The
I have. I'm a
sepsis
loyal
6,
listener.
man.
I'm
Hey.
the 1 p.m. podcast listener.
And I want to break it down. There are 3 in
Yeah,
and 3
3
out.
out,
So
yeah.
you do the 3 in, and we get Jade to do the 3 out to
Yeah.
see whether they fucking listens. Okay?
All right. So sepsis 6. So 3 in is oxygen, and then IV line, you want to give them fluids and antibiotics.
Brilliant, Nick.
Yeah.
I'm so impressed, man.
Thanks,
Such an
man.
avid listener of the
I
show.
listen so much.
Okay, now Jay, you were on this episode, man.
So,
Standards are high.
3 out: blood cultures, VBG, and catheter for fluid balance. Urine output, basically.
Great. So yeah, blood cultures, BBG, and urine output and vital signs reassess. Blah blah blah. Okay. So you
I
guys,
still think it's better to think of them as groups. So when he was talking about the VBG, you're doing lactate, right? And so in response, you give oxygen because they're paired together. You take blood cultures, and in response, you give them antibiotics. And then the last one is fluid balance. Then you give them IV fluids,
that's actually not bad.
and then you get
Usually,
6.
usually when you say
Fuck
shit,
off.
it turns out to be real stupid. So
Write
write that down.
All right, we'll move on.
Anyway, that's the end of the case, man.
Did we save the life?
So for shock, right? The 3 key steps, you've done a thorough A to E assessment. You've established the likely cause of the shock, and then you've treated the underlying cause of the shock. Okay, job done. Saving lives, mate.
That's what
Saving
you get
lives.
paid for.
Okay, so the 5 key takeaways. Shock is a life-threatening state of cellular and tissue hypoxia due to either and/or a combination of reduced oxygen delivery, increased oxygen consumption, or inadequate oxygen utilization. And shock must be recognized and treated early to prevent progression to irreversible organ dysfunction. And as we know, shock is categorized into 5 different types, which include distributive, cardiogenic, hypovolemic, obstructive, and combined. And when you're examining a patient in shock, the different types of shock can be differentiated based on their peripheral temperature, their JVP, and their breath sounds. And finally, once a patient is stabilized with an AT assessment, the underlying cause of shock must be investigated and treated. So those are 5 simple key takeaways. Okay. Thank you all for listening to another episode of 1 p.m. Please make sure to check out the Notion page because I put a lot of effort into it. And I feel
It
like
looks
no
very
one actually
colourful,
looks at
Jason.
it. But anyway, thank you, Nick, for coming on.
No worries. It was a
Hope you
Pleasure.
enjoyed
pleasure.
yourself.
Yeah, I had a great
I know
time.
you're under the gun considering you guys haven't done ED. So
That's all right.
you guys did well now. Now you're going to ace
Then we
that
rock
shit,
up.
man.
Yeah.
This
You'll be like
will
A to
cook.
E, bro. Any day, man.
Yeah.
But thank you guys for listening and see you next time.
We're really excited to be collaborating with Becky from Becky's Notes. Becky's Notes bring together all the key topics medical students need to know in a readily available place, reviewed by specialists in the field. These visually striking notes are a refreshing change from all these boring textbooks out there. You can check her out on Instagram at Becky's Notes 01 and support her at the links below.